Okay, welcome to today's webinar. I appreciate you joining me for today's topic, which is treating shoulder rotator cuff tendinopathies and impingement syndrome, kind of similar, kind of same thing. And we will get started. If you haven't, in the chat box, let me know your name, where you're from, if you're using BIOFLEX laser therapy, or maybe you're interested in laser therapy. Let me know what profession that you are. This webinar will be about half an hour. It is recorded. And if you don't have a chance to watch it all and you want to rewatch it, it is uploaded to our website within a week or so, but also you should get an email with a link to it. That's for all the webinars. So my name is David Kunashko. I'm the medical director here at BIOFLEX Laser Therapy. I'm a chiropractor. I also trained in traditional Chinese medicine and acupuncture. I've practiced over 30 years, a graduate of U of T in molecular genetics and CMCC, the Chiropractic College here in Toronto. So I'm going to review the anatomy. It's always good. I used to teach a lot of anatomy at different colleges, and I think it's a good idea to review it. Sometimes we forget a few critical things. And then I'll go over the etiology, pathophysiology, and some of the symptoms that we're probably familiar with, although this might, be a good refresher. Then I'm going to talk a bit about some conservative treatment, specifically some exercises that, should be helpful for this type of condition. And then we'll get into laser therapy or photobiomodulation therapy or PBMT, some of the research and some advice on how to use your BIOFLEX equipment on the professional side to treat these questions. And then if you have any questions at the end, I'll certainly get to those as well. Type them into the Q&A box as soon as you have them. Oh, okay, anatomy. I always love looking at Leonardo. I'm a huge fan of his, and here's a nice diagram of the shoulder area. But we'll go into a little bit maybe more modern pictures. Of course, we know the rotator cuff consists of the sits muscles, the supraspinatus, subscapularis, infraspinatus, and teres minor, forming a common tendon in the shoulder. The other main piece of anatomy we probably need to be concerned about here is the subacromial bursa. This one kind of is not a good diagram, but it's obviously lies in between the common tendon and the supraspinatus and the inferior surface of the acromion to reduce friction during movement. So this is a little bit better diagram, and you can see here, normally the bursa is a very thin fluid-filled sac, and its, of course, its purpose is to reduce friction. So you can see here it lies in between the acromion and that supraspinatus and the other common tendons as they insert into the tubercle of the humerus. It's this area that we're concerned about with today's webinar, because this is where you get impingement and tendinopathy issues in the rotator cuff. And that's what, the source of many shoulder problems. It's a high percentage of shoulder problems that are involve the rotator cuff. Obviously, these muscles help to stabilize the GH joint and help in specific movements. We're all aware of that. We also know that's a common cause of shoulder pain. These particular tendons, especially supraspinatus, are very susceptible to compressive forces of the subacromion area. And that's why you tend to see these issues. It's caused by lots of different things, and oftentimes multiple different issues, including, in athletics, poor technique. It could be throwing something or golf or whatever, poor posture, poor conditioning, especially if you're not doing exercises and keeping the muscle and the tendons healthy. Anytime you get acute inflammation into this area, it can lead to degenerative changes, tendinosis changes, and eventually it can lead to tears as well. So it's oftentimes progressive, and that's why you see these issues, especially as people get a little bit older, as they age. So it's one of the most common problems with the shoulder, and they say that it counts for about 2/3 of all shoulder cases. So, you know, it's everywhere with when people come in with shoulder problems. And as I mentioned earlier, this rotator cuff tendinopathy, you can basically refer to as subacromial impingement, because the two are synonymous as far as you get swelling and reduced space in there, irritation of the bursa and the tendon, and so it all tends to go hand in hand. So acromial irritation itself tends not to be the primary cause of the symptoms. It's not really quite sure what's causing pain in these scenarios. Now, the stats show that over 50% of all patients diagnosed with rotator cuff tendinopathy seem to be fully recovered within the first 12 months, which indicates that this type of problem takes a long time to resolve, and sometimes it doesn't resolve properly. So really, this type of issue should be treated. You know, people with shoulder problems, that kind of thing, you're best to get it treated. And clinicians know this, because if you don't get it treated, it can last much longer, 12 months or even longer, and maybe not even resolve. And that's why therapy is so critical. So there's different mechanisms and different sources of pain that are hypothesized for this condition, including intrinsic and extrinsic mechanisms. Extrinsic would be things like reducing the strength of the tendons due to contact with structures. So that's where you get the true impingement, poor function of musculature, fatigue, pain-related inhibition. So, you know, if there's painful structures in the area, what have you, then this will cause issues with the mechanics. And any structural incompetence, you know, reduction of the subacromial space, it could be even hereditary or spurs or what have you, that can also cause problems. Intrinsically, you know, these are things like aging and genetic issues, disease issues, altered loading issues. Excessive tissue load is by far the most common factor that causes the development of rotator cuff tendinopathy. And we know this because it tends to occur most frequently in the dominant limb. So especially in occupations and sports where you have high rates of upper limb loading on your dominant side. I mean, you can just think of baseball pitchers, for example, right? On the flip side of that, underloading can also disrupt tendon homeostasis. And this can lead to earlier point failure. So essentially, as people age and they're not active, they don't keep their muscles and tendons in good shape, then they go to do something and bang, oh, they get a problem because, you know, that tissue hasn't been maintained. And that's why it's important to encourage people to constantly do exercises, strengthening and stretching, especially strengthening. Asymptomatic partial and full thickness rotator cuff tears have been reported in 50% of people in their 7th decade and 80% of people over the age of 80. So it's extremely prevalent. Now, the current research evidence provides considerable confidence for people diagnosed with rotator cuff tendinopathy to expect an equivalent outcome of surgical intervention with a well-structured and graduated exercise program. So in other words, don't go under the knife, just be persistent, see a physical therapist, a physiotherapist, a chiropractor, a massage therapist that understands and knows how to get their patients doing these exercises and monitoring it, because these patients need monitoring, especially initially, to make sure they're doing it correctly. Now, of course, we know the hallmark of this condition is pain and weakness experienced, especially during shoulder external rotation and elevation as a consequence of excessive load, right? So a significant proportion of individuals with this issue have pain radiating down the arm and even some hyperalgesia to pinprick stimulation of the skin. So there may be some central sensitization looping into the innervation at the spinal cord level and the neck. So it's really important to look at the neck and examine the neck as well. And oftentimes I do recommend that if they have some of these symptoms as well, is that you're treating the neck. And most practitioners are going to treat the shoulder complex and anywhere else that makes sense, but don't ignore that. Don't be hyper-focused just on the shoulder. Look to perhaps other sources of radiating a pain, and maybe it's not even rotator cuff that's causing the pain in that general area. We know that impingement occurs in that painful arc. I'm not going to spend a lot of time on this. It's when that greater tubercle tries to ride underneath the acromion, and then if there's less space for that bone, then it's going to pinch or push and then be painful in that 60 to 120 degree range where you have that bony protuberance pushing in there. Here's a little bit better diagram. You can see on the left a normal sort of tendon and bursa, although that's a little exaggerated. But when you get a tendinosis, the tendon thickens. So when the tendon thickens, and that's because of immature collagen breakdown of the tissue. So it's a degenerative condition, not so much an acute inflammatory tendonitis issue. In a tendonitis, you don't see as much swelling. It's more inflammation. But in a tendinosis, you get actually a space occupying kind of issue going on there. And that's what's causing the impingement. And tendinosis is chronic. So the prognosis is much, much longer than a tendonitis scenario. So number one is when patients are coming in and you figured out that it's a tendinosis and a chronic problem, you need to ensure that the treatment plan reflects that and is going to be long enough to ensure clinical effectiveness. I won't spend a lot of time on these exercises, but here are some examples of some great exercises. In general, they recommend building up to 3 sets of 10 repetitions using different strengths or elasticity, resistance, elastic resistance. What am I trying to say there? You know what I mean? So it could be rows, straight arm pull downs, external rotation, internal rotation. Now remember that these sometimes might be a little bit painful. So you want to make sure that the client's aware of that they're not overdoing it, not overzealous, but they do need to be strengthening and working on these tissues. You just don't want to overdo it. And unfortunately, I've seen some clients that overdo it and they cause more problems. So you need to be careful with that. Palm up, band, pull aparts, doorway stretches. Those are all exercises that can be very helpful. So why photobiomodulation? And those of you who have been watching webinars or are familiar with laser therapy or photobiomodulation probably know a lot of this already. But those of you who are new to this type of therapy, I'll explain what the deal is here. Photobiomodulation, as you know, involves light, and light can interact with chromophores, which are photoreceptors. And there's many in the body, right? There's melanin and hemoglobin and myoglobin, cytochrome, lots of different things that absorb light. Now, light has energy, right? It's a photon of energy. That energy can be converted into chemical energy or mechanical changes once it's absorbed. And the easiest way to understand this is photosynthesis, where the photons of the sun are absorbed by chlorophyll in a plant. That energy is converted by the chlorophyll to allow the plant to grow, right? So that's a photosynthesis or a photochemical reaction, right? We all understand that. In the human body, certain wavelengths of light can do lots of different interesting things. And what they found was that specific wavelengths that end up being absorbed by cytochrome C oxidase, which is one of the terminal enzymes in the electron transport chain. One of the mechanisms here is that when you have inhibition of electron transport chain by increased nitric oxide due to inflammation, everything slows down, including production of ATP and metabolism and mitotic index and the ability of cells to repair. So when enough light of the correct wavelength interacts with the cytochrome C oxidase, it actually allows oxygen to bind where nitric oxide was binding. And that's a whole process. I won't go into it today, but by doing that, and if you bombard the tissues long enough, note, long enough, if you do quick, fast treatments, you won't get this effect or get minimal effect. And those of you who just want to treat their patient really quickly, this isn't for you. This therapy takes a bit of time, not hours, but not a minute or two. All right. So you need to understand that, that you need to spend some time with your patient to elicit this photobiomodulation effect. So essentially, the end result is increasing ATP, releasing of nitric oxide, slight spike in ROS, which are reactive oxygen species, which have a protective effect by producing stress proteins in the cell. Along with all of this is you get increased repair of tissues, reduction of inflammation by different pathways, vasodilation through release of nitric oxide and increased circulation. It has an impact on white blood cells, which I won't get into right now. It reduces edema through lymphatic vasodilation and increased circulation. And it can have analgesic effects and help modulate collagen and scar tissue formation and maturation. There's, I don't know, 7,000, 8,000 research papers on the topic of photobiomodulation or low-level laser therapy, 1,700 randomized controlled trials. It's evidence-based to the point where it shouldn't really be questioned that it's helpful. And I say that because it is now part of guidelines by the Center of Disease Control in the United States, by the American College of Physicians for low back pain, papers in Lancet, papers in Nature and Science. You know, if you know what you're doing with this therapy, you will have good results in conjunction with what you do already. There's critical things to understand here. One is a direct effect of photobiomodulation, which is kind of what I laid out earlier. That's where the light is absorbed by the tissues that are injured or diseased, and it helps them recover, right? The other thing about photobiomodulation that's fascinating is a systemic or remote effect. And that's actually, to be honest, something that we kind of specialize here at BIOFLEX, because we use a slightly different type of piece of equipment to induce this. And this is where you have light that is treating a large volume of underlying tissue and blood, including white blood cells. White blood cells, when they absorb these wavelengths of light, they're triggered to basically shift towards an anti-inflammatory state. You probably know white blood cells start inflammation and resolve inflammation. But there's different states of macrophages that do that, different states of white blood cells that do that, and they're triggered by chemical mediators, right? When you have chronic inflammation or inflammation that's not resolving, the pro-inflammatory cytokines and pro-inflammatory white blood cells in the area are not resolving, and that's the problem. There's a shift towards the anti-inflammatory white blood cells and release of those cytokines and leukotrienes and so forth that occurs when you treat this large volume of blood and tissue around the area. It's a super fascinating topic, one that was first understood back in the 60s, but now we're starting to see a lot more research and understanding of this phenomenon of sort of a localized, you might say, systemic effect, which helps with underlying deeper tissues and inflammation. Just one paper, there's many papers, but just one I want to talk about as far as laser therapy goes and shoulder impingement. This was a randomized control trial that looked at laser therapy group, laser therapy plus exercise, or exercise alone. I think, yeah, that's right, exercise alone. And so this a paper in part was published by Jan Bjordal, who's a physiotherapist, PhD out of Sweden. I think he's considered the preeminent researcher and key opinion leader on physiotherapy and use of photobiomodulation. He's well published, well respected in the field. They looked at 120 patients that had impingement syndrome. They were divided into these three groups. So essentially low level plus exercise only, and low level laser therapy only. Sorry, that's how they divided them up. I was a little bit wrong there. And they did the intervention for 3 times a week for 8 weeks. Okay, so this is really important because the treatment plan when your patient comes in is not a couple weeks. It's 2 months, maybe 3 months. Be upfront. and make sure they understand that. So the participants received therapy 3 times a week. I just said that. They have 3 joules of energy. Now, just so I can relate this to BIOFLEX, if you use BIOFLEX, if you use the LDI 200 or infrared probe at 100%, that's about 17 seconds per point to get 3 joules at 100%, just so you can understand that. I'm going to talk about this a little bit later on. So they irradiated only 3 insertion points, which is not a lot. I mean, when you use our equipment, you're going to do more points than that, but just they chose 3 over the supraspinatus muscle tendon. That's good. On the subacromial bursa, that's good. And along the bicipital groove, I don't know. I guess that's okay. I would have maybe they aimed it up a little bit. I'm not sure. Total dose is 27 joules per treatment. They also did these exercises in different stages. So the first 6 sessions, they also did these stretching exercises. Then they did a second stage of exercises, 3 sets of 15 repetitions with a 1 kilogram load. Then they did 3 sets of 15, again, with a 1.5 kilogram load. So you can progressively increase, and that's the whole goal, right? Is to increase strength and function. And here are the results. So follow the bouncing ball here for me, okay? So they looked at pain. They looked at pain at rest. They looked at number of days of analgesic use. Then they looked at the shoulder active disability index, which is function, that kind of thing. The higher the score, the higher the SPADI score, the worse, right? So in pain, post-treatment, that's 8 weeks, the combined group, laser and exercise, went down from a 6.8 to a 0.2. The exercise group only went down to a 0.5. The laser only went down to a 2.4. And then follow-up, oh gosh, I wish I knew the time there. I don't remember. I think it was a month later or 2 months later. Shoot. Okay, I forget. Follow-up, I should know this. The pain stayed at about 0.3 for the combined group, went down to 0.2, which is pretty good for the exercise group, and stayed and went up a little bit just with the laser group only at 4. And then pain at rest, you can see the results were significantly better for the combined group compared to the laser or exercise only group and the laser only group. And then the analgesic requirement after follow-up for the combined group went from post-treatment of 1 to 0.15 number of days. So rarely would they use it analgesics. And then for the exercise group alone, you can see it was still pretty high, 3.3 and then 3.4. For the laser only group, 1.9, 2.4. Laser is really good with pain. That's part of the reason why you see that a little bit better than just the exercise alone group. Then when you look at function, you can see the baseline for the groups were around 50, 62, 67. And then the laser and exercise group went down to a 0. That's for function. And then you can see only went down to 16 or 26.5 for the exercise only, and went down to 41 and 43 for the laser only. Okay, so combining the two are definitely better. I can't spend a lot of time on this just because I'm running out of time here. And similarly, I'll run through all this as well, but it's similarly statistically relevant, again, showing you much better function with combination of laser and exercise than just one or the other. Okay, and that makes sense, right? But as a rehab specialist, you might just be doing, the exercises and some other things or whatever. But when you add that laser, it really does help with all aspects of recovery. So they obviously found that low-level laser therapy combined with muscle strengthening exercises reduces pain intensity, improves shoulder function, and reducing medication over a period of 3 months. Oh, it was 3 months. So it was another month after, that was a follow-up. So it was 3 months after the first treatment was the follow-up. Okay, so let's talk a bit about using our equipment. And for those of you who are new, there's two pieces of equipment that are critical. One is a large surface array of light that uses high intensity bicolor LEDs that covers, I don't know, about 100 square centimeters of tissue, and a class 3B probe or probes, near infrared and red is what we do. So these two pieces of equipment are what we use in our protocols. If you have our equipment, then you know that we have a shoulder protocol specifically, and they go in stages. Now, you're always going to start at stage 1. Notice that it's pretty low frequency and duty cycle, 10 and 40. You could even go lower in the duty cycle to 20 or 30 if the patient's in a lot of pain. Frequency is the pulses per second. So initially, the first week and a half, maybe longer, you're going to stay in the stage 1 protocol. If you're seeing a slow recovery or plateauing, you can increase the parameters. You can go jump up to 20 hertz, 50, 60, 70% duty cycle, and then make your way up to stage 2 and eventually to stage 3 if necessary. Speaking, I've been doing this for 12 years now, and most BIOFLEX users find that stage 1 and 2 are the optimal. I've had some that say stage 3 seems to be the minority, but you have to play around with it. But typically start with stage 1, work your way up to stage 2 and 3 if necessary, but give each stage 2, 3, 4 sessions. If you're not seeing improvement or plateauing, then you can increase the parameters or go to the next stage. The placements here, now you might go, well, why do you need to do all these placements? And it may seem time consuming, but if you have our newer equipment, like the dual or the multi-port, you can do at least 2 of these placements at the same time, which is good, which cuts down the time. You're going to want to cover the anterior aspect. You want to cover the lateral aspect. You want to cover the posterior aspect. That's because of the access to the muscles involved. You have the sits muscles, and they're all around the shoulder, right? And you have the subacromial space in the front of the shoulder. So it just makes sense that when you want to treat around the entire shoulder. But also, too, remember earlier I talked about the systemic anti-inflammatory, a kind of remote effect. And this is what helps. When you treat around the shoulder, you will be getting this systemic effect that will circulate deeper into the tissues that are involved, including the tendons and the bursa and the other musculature or other tissues that are affected. You can keep the array in place using one of these weighted devices. Or cushions or whatever. You can try and strap it in. It's a little awkward. You can put it underneath a patient's clothing. There's different ways of keeping a position. They can lean back into a pillow. That's okay. Just make sure the array doesn't get too warm. Try not to cover it if possible. But typically these arrays are pretty good for that. Just always communicate with your client. During this stage or these stages here that I'm showing you, it's hands-free. You don't need to be with the client. You can have an assistant, or if you put it on, it's roughly 10, 11 minutes before you need to move it to the next position. If you're treating 2 areas at the same time, then you're looking at roughly about 20 minutes of total treatment time to do these 3 placements, and then the laser probe. So, 20, 25, 26 minutes in total to do that. If you're in a pinch and you don't have quite the time to do that 3rd placement, then probably what I'd recommend is a posterior placement and the anterior placement, and maybe can shift it over a little bit to get the subacromial area as well and the lateral aspect. So, if push comes to shove and you're stuck for time, then those 2 placements should work as well too. The 3rd one is kind of a bonus one if you can do it, which is helpful as well. So again, you want to treat around the entire joint. Start with pretty low frequencies and low duty cycle. The shoulder is sometimes kind of sensitive, so see how they respond, and then especially if they're in significant pain when they first come in. The first stage of the protocol, the class 3B LDI laser is set to about 75 milliwatts. So based on that, if you want 3 joules, you're going to hold it for about 40 seconds per point. That's really important. I prefer slightly lower power on a laser and holding it for longer than high power holding it for a very short time. And the reason for that is that if you think about what you're trying to accomplish, you're not just trying to spike in a nail, right? You're trying to let the light get absorbed by the tissue to create a photochemical reaction. The longer you do this within a certain time frame, the more reactions that are going to take place. Go back to chemistry class. When you're doing an experiment in chemistry and you add the ingredients or whatever it is you're trying to do in the beaker, you don't just kind of leave it there and let it sit there. Do you remember you put them on, you put one of those old magnets in it and it spun it around to mix everything together over a period of time to ensure that the reaction takes place? It's kind of what you want to do with laser. You don't want to do it super fast. Now, I know there's argument there about class 4 laser and why it's so great and it's really quick. Practitioners love it. It's not photobiomodulation therapy. It's way too high. It heats up tissues. And it doesn't create this effect of stimulating the receptors over a little bit longer period of time. Remember, the laser is the only hands-on part here. So it only takes you 4, 5, 6 minutes to do this part. It's pretty easy to do. You need to know your anatomy. When you go to stage 2 and 3, a little bit higher, the laser probe is now set to a full power. So now you don't need to hold it for about 17 seconds. You can customize it and keep it at 75 milliwatts if you want. That's my preference. But if you want to increase it, then you should shift the amount of time down to about 17, 20 seconds or so. It's really important to depress or push in the laser probe into the tissue. This allows, number one, to push blood out of the way to allow light to go deeper and get the source of the light close to your target. Light can't penetrate very deeply. So by assisting the depth of penetration by pushing in the tissues allows you to get the light even closer. I'm seeing questions, which is great. I'll definitely get to those at the end. So you want to target the tendons from different angles, as well as any tender and trigger points in and around the sits muscles. So focus the laser probe on the pathological tissue involved, in this case, mainly the tendon. That's what needs to be healed. That's where you're going to focus the light. If you're using a red laser probe, which I highly recommend, set that to 100% power, hold for 20 to 40 plus seconds per point, more on painful spots, not so much the pathological tendon. This is very helpful for pain control. You might also want to position the glenohumeral joint in different positions to allow exposure to the rotator cuff, especially adduction of the GH joint, which, if you think about it, it stretches out that tendon and exposes it a little bit more for irradiation with the laser. And of course, you're going to be adding the exercises and manual therapy and looking at the cervical spine as well. Once you've treated the points, you can go back and treat them a second time if you have a bit of extra time set up in your system. So again, anteriorly, this is anterior view, you're going to be treating in and around the supraspinatus, so underneath the acromion. Don't point it on the bone. There's no point. You want to get it on soft tissue. You want to aim it towards the supraspinatus tendon and the subscapular tendon coming in towards that greater tubercle. It might take, I don't know, 2, 3, 4 different spots around that area. I know in the research that they just one, but I think the more the merrier here because you get more of the tissue involved. Lateral approach, adduct, and then treat on top to try to get that tendon. And then posterior approach, the supraspinous fossa, that's going to get more of the muscle of the supraspinatus, and then just underneath the acromion and inferior to the acromion blade and into the insertion of the common rotator cuff tendon. Sorry, just have a little tickle in my throat. Okay, I hope that was helpful. Now, next events we have, I'm going to be in Vancouver on tomorrow. And we're doing a Let Up Your Practice event at the Blue Horizon. If you're listening in the Vancouver area, haven't signed up or you want to come by, even if you've taken the training, I think it'd be fun to come out because we have guest speakers, including Dr. Pierre Delorier, a chiropractor who's been using BIOFLEX for pushing 10 years. Really great dynamic speaker. He's going to talk about his integration of laser therapy into his clinical practice, some case studies. It just in general, he's super fantastic to listen to. So it'd be fun to come out. And Dr. Lauren Brown, a TCM practitioner that has specialized in using laser therapy now, especially for fertility issues, as well as general practice in his acupuncture and TCM practice. Again, a dynamic speaker, a well-respected world expert actually in this. So if you have a chance, you're interested in that, you can sign up or contact us. I don't know if we're sold out or not, but maybe we can squeeze you in if you take me out for beer or dinner or something. And then we're also doing the same event in Ottawa as well with some different speakers. Okay, so let's get to these questions here. Is there a point in doing laser for an 85-year-old who has frozen shoulder for, wow, for 40 years? Don't want to offer false hope or expectations. Yeah, Jill, I mean, that's a great question. I think, you know, I think it's worth it, but with expectation that, you know, it may not do a lot, but I've seen severe chronic cases come around and it be helpful. But you know, the prognosis is not great. So end of the day, there is cost prohibitive aspects to it because the treatment plan is going to be not just 2 or 3 sessions. So it's more of a comfort level, but I think it's still worth it, if you ask me, Jill. When treating a patient, is the best protocol to complete stage 1 and 2 with the same treatment? Or is it recommended to just begin with appropriate stage? Okay. So I'm not sure who this is asking the question, but in training, I talk about these stages. And as I mentioned earlier today, and this is probably rehashed now, the stages are levels of both intensity and stimulation. Always start with the lowest level you can, because oftentimes that's what's going to do the trick. And treat the client with that same protocol on 2, 3, 4 separate occasions. Don't mess around with any protocols until you've seen if that's working or not. And as I alluded to earlier, if it's not working, then you can increase the stage and or just customize the protocol a little bit. How would you approach this condition if it is more in a chronic stage with calcification? Calcification is crazy because that's what causes tons of the pain, like a lot of the pain. So, you know, laser therapy is not going to do anything for the calcification. That's the body resorbing. When it's painful, my understanding is that that's when the calcification is being resorbed by the body and it causes pain. So I would treat it the same way, but at the same time, maybe spend a little bit more time trying to focus energy, if you know, in and around where that calcification is, which is usually the tendon anyhow. But it's a poorer prognosis and a longer prognosis for calcifications if they're involved. Can I use a P80? Yeah, P80, exactly. Do exactly what I just said there, except that you don't have a laser probe. So same deal. Can we get a copy of the exercises? Well, this webinar will be made available on our website, so you can just get them from there. I unfortunately didn't put the reference there. My apologies. So I'll see if I can get that up when we put up the webinar on the website. Question is, will the home system give the same results? Well, here's the thing, right? The advantage of the home system is you can treat more frequently. So you can oftentimes, by doing that, without having a laser portion of it, you'll still get really good clinical effectiveness or help for this treatment. So I would say yes, provided you're doing all those other things, the exercises and everything else. Does a laser probe add to it? It does. There's without a doubt. There's that aspect to it. But if I had this problem and I only had access to a personal home system, I would do it. If I had access to clinic, I would go in for the laser as well as I can do the array portion at home, but the laser portion, you can go into clinician and have that done as well too. Listen, thanks everyone for joining me today. I hope you found it informative. Really appreciate you taking the time to stay with me. Yeah. So I think that's about it. If you have any follow-up questions, email me, david@bioflexlaser.com. If you have any inquiries as far as sales or whatever, then you can contact our sales team. I'm sure there's information on our website for that. And let's see if there's any other questions. That's about it. Have a great day, everyone. We'll see you next time. Bye now. Or in Vancouver if you're out there. Bye now.